Today, I would like to welcome our patients, aPS advocates, and healthcare professionals in the audience. We hope by hosting this roundtable, will have helped spread awareness on aPS and the impact on affected patients. I would like to start this roundtable by thanking each of you for joining and being willing to share your stories and experiences. Before we get started, I would like to provide this disclaimer. The information in our webinars and e-materials, digital recordings, and other materials is for general information and educational purposes only. Nothing contained in these materials is or is intended to be construed as medical advice. Uses of specific medical devices and other products discussed in this educational activity may not be the same as those indicated in product labeling approved by governmental regulatory agencies. Before requesting any therapeutic agent or device, attendees should review specific labeling and instructions for use provided by the manufacturer. I would also like to ask our panelists to avoid mentioning names of specific healthcare providers and institutions. Tonight, we will listen to the experience of 5 patients with ongoing antiphospholipid syndrome and learn more about their symptoms, journey to diagnosis, treatment, and impact on their lives. We are also excited to welcome LaShonta Bryce, who is a DCLS and member of the Scientific Affairs team at Diagnostica Stago. LaShonta will be discussing the different laboratory testing that is involved in diagnosing patients with antiphospholipid syndrome. Additionally, we welcome Dr. Stefan Mull, a hematologist and thrombosis specialist from UNC Chapel Hill in North Carolina. Dr. Mull sees a wide variety of patients with clotting and bleeding disorders, and over the years has been much involved in healthcare provider and patient education about blood clots. Dr. Mull works with athletes affected by blood clots and has even helped care for an astronaut from the International Space Station with an unusual blood clot. Dr. Mull, what are some of the key things patients should keep in mind regarding antiphospholipid syndrome? What do you find is the biggest knowledge gap among healthcare providers? And can you start us off with an introduction on antiphospholipid syndrome for our audience?
Well, thank you very much, Emily. If we look at the first slide, I realized that the patients obviously know about DVT and PE and arterial events, and we'll hear more about that in a minute. But for the ones in the audience who are not that familiar, I want to first briefly talk about vein clots. Emily, is there any way I can have control over this, or do you forward each time?
I think I have to forward it.
Okay, please forward.
Sure.
So the vein clots are, number one, deep vein thrombosis in the leg, often referred to as leg clots. Secondly, if you forward, pulmonary embolism, that's a clot in the lung with shortness of breath, cough, phlegm, cough, chest pain. And thirdly, next one, sometimes unusual clots in the abdomen, in the liver, spleen, intestine, kidney, etc., and sometimes around the brain. Next one. Then patients with antiphospholipid syndrome can also have clots in the arteries. First one is clots in the leg, also referred to as gangrene, with a cold, painful, pale leg. Secondly, a heart attack or stroke, either as a mini stroke with transient neurological symptoms or with lasting neurological symptoms. And then thirdly, a heart attack. Those are arterial clots. And lastly, clots can also occur in unusual sites, such as in the intestine, in the kidney, the spleen, etc. Next one. The antiphospholipid antibodies for healthcare professionals, as well as for initially diagnosed patients, that's often a very confusing terminology. And at least for the healthcare professional, people need to be aware what is really relevant and what is not relevant. There are 3 types of antiphospholipid antibodies, and the patients in the audience likely know what they are positive for. But the 3 tests that really count are, number one, the lupus anticoagulant, also referred to as lupus inhibitor. You see that on the left. Then secondly, the so-called anti-cardiolipin antibodies. There are 2 subtypes of that, a so-called IgG, that's more important, and an IgM, that's less important. And thirdly, the anti-beta 2 glycoprotein 1 antibodies, again, as a subtype of IgG, more important, and IgM less important. Now, some profile when people, for example, with pregnancy loss, which can also be associated with antiphospholipid syndrome, or with arterial venous clots, when they get tested by certain healthcare professionals, sometimes a profile is done with a number of different antiphospholipid antibodies. And I've written them in gray and crossed them out because they are not well-established risk factors for any of these clinical complications. They are research tools, but should not be used clinically. Next one. And I highlight this mostly because on the right side, you see in 2023, there will be new definitions and criteria coming out to define the antiphospholipid syndrome. But over the last 20 or almost 25 years, healthcare professionals have used the so-called Sapporo criteria developed in 1999 that were then developed into or modified into the 2006 so-called modified or updated Sapporo criteria, also referred to as Sydney criteria. And they've been used for many years to define as what is antiphospholipid syndrome. They're relatively coarse and not very accurate criteria. So they will be replaced in the very near future with additional or with new, more defined criteria that I'll mention in the next couple of slides. Emily, next one. And without overwhelming the audience, the antiphospholipid syndrome, typically there are clinical criteria and then there are laboratory criteria that define the syndrome. The clinical criteria, as I mentioned earlier, on the left we see the vein clots, DVT and PE, and unusual clots. Then secondly, it could be arterial clots. And noteworthy is that with the new criteria, the healthcare professionals will weigh what was the clot really triggered by, because often blood clots are due to multiple risk factors: hip replacement, knee replacement, hysterectomy. Sometimes they're out of the blue or unprovoked. And the typical antiphospholipid syndrome patient has an unprovoked, out of the blue clot. And these new criteria weigh these different types of clots, what triggered them, by giving them points. And you see that, for example, a vein clot without any risk factor gets 3 points. A clot that is triggered by an external risk factor gets only 1 point. And this is important because the more points eventually are counted up, the more likely this patient truly has a full-blown antiphospholipid syndrome. The same is then true for arterial clots. If they were completely out of the blue without diabetes, hypertension, cholesterol, smoking, one puts there 4 points for stroke or heart attack. And if there are arteriosclerosis risk factors, one puts only 2 points down. And then sometimes people with antiphospholipid syndrome have blood clots in small vessels in the kidney. That's called microvascular involvement. And there one also puts points into whatever the clinical presentation of the patient is. And then, as I mentioned, people can have obstetric complications, either pregnancy loss, preeclampsia, etc. And again, depending on whether there are other risk factors that may explain those pregnancy complications, the patient gets very few points or more points if this is clearly unexplained. And then sometimes patients have heart valve thickening or growth on the valves, which can occur in antiphospholipid syndrome, and points added up if that is present. And sometimes patients have low platelets due to platelet destruction in antiphospholipid syndrome, and 2 points are given for that. And then next one, Emily. If there is a suspicion for antiphospholipid syndrome, certain testing is done, and we'll talk more about that. And I mentioned the 3 tests: the lupus anticoagulant, which is really the strongest risk factor for blood clots. And if it's persistently positive, 3 or more months apart, that adds 5 points to the scale. Whereas if it's only a one-time positive test, one only has 1 point. Anticardiolipin or anti-beta 2 glycoprotein 1 antibodies, the other 2 positive tests, really depending on how positive those tests are. If they're strongly positive, there are 7 points added. But if it's only a moderately elevated test, only 4 points are added, which reflects that it's important how positive the test is. Next one. So these antibodies, as I mentioned, can fluctuate over time. The light blue line shows a persistently positive test that is the more relevant and more in keeping with antiphospholipid syndrome. The red line shows a transiently positive test, which occurs not infrequently in patients who present with blood clots, positive at first, and then they turn negative over time, and some patients have fluctuating levels over time. Next one. So the take-home points for the healthcare professional, if people are on the line, and what I teach to healthcare professionals, what to consider is, number one, to only test for the recommended 3 established tests that we mentioned, the lupus anticoagulant, anticardiolipin, and anti-beta-2, IgG and IgM antibodies, not those that I had in gray. Then the physician needs to be clear about the interpretation of the lupus anticoagulant, because those tests can be false positive if tested at the wrong time or while on a blood thinner. So one needs to really interpret them with care. And the levels of tests are important. The higher the test, the more relevant, which I showed you get more, or a patient is counted for the score with more points if the tests are more strongly positive. The number of people who have these very slightly low levels, gray zone, of questionable clinical significance, and one really needs to be aware that one does not label those patients as having antiphospholipid syndrome. Next one. And then there have been some studies on antiphospholipid syndrome, on best management, on association with certain clinical criteria, but assessments have been made, and this is a quote from a good review article from a few years ago. The overall quality of evidence of clinical studies is very low. One cannot be dogmatic because many of the studies have limitations, either which kind of patients were enrolled, how positive or how negative were the tests, how many of the tests were positive, etc. So it really is important when somebody's labeled with antiphospholipid syndrome to be clear about why does one say this patient has antiphospholipid syndrome, and not to be dogmatic about any of the treatment decisions. It needs to be a discussion with the patient. And I've added as a last point, a duplication, because sometimes we hear physicians being dogmatic, you need to be, or you should be, or definitely you need to be on warfarin rather than Xarelto or Eliquis, for example. And one has to be careful not to be dogmatic because clinical trials have been of low quality and low evidence. And then next slide. This is more a general point, also to include patients or people who may not make the clinical decisions with patients. Antiphospholipid syndrome, and we'll learn that in the next hour, does not equal antiphospholipid syndrome. Details matter. What caused the blood clots? What other risk factors were present? Is there a family history? What other clinical symptoms are present? Was the clot, as I showed earlier, provoked by a risk factor, or is it a truly out of the blue unexplained clot? Is the patient single, double, or triple positive for antiphospholipid antibodies? I've mentioned how important the titer is, the level, and the IgG antibodies are more important than the IgM. And then really one has to be careful when interpreting the lupus anticoagulant. Then if people ask about or interested here on the call, and we may get to some questions about best treatment for blood clots, DVT or PE. Well, we know that warfarin has a failure rate, that it's not 100% effective. But similarly, in the last 3 years, we've learned that Xarelto and Eliquis have a failure rate as well. So neither Xarelto or Eliquis are the best choices in every patient, nor is warfarin the best choice in every patient. And we've learned that particularly people who are triple positive for all 3 tests, strikingly and clearly positive, they tend to have some, or at least some of them, have a higher failure rate with new clots when they're on Xarelto or Eliquis, and in those people, the traditional old-fashioned warfarin or Coumadin may be better. But again, one cannot be dogmatic. And then an issue that comes up every so often, maybe it will come up later, a patient who has had an arterial event like a heart attack or stroke. The question is, what is the best treatment for that? Is it aspirin, like usually in stroke or heart attack patients, or should they be on a blood thinner, warfarin, Xarelto, or Eliquis, or maybe a combination of the two? And then the other issues that may come up about clinical trials and use of more unusual medications. And I think, Emily, that was my last slide. If you forward,
Yes,
we're
that is
getting back
your
to
last
yours.
one.
Good.
Wonderful. Thank you. One question for you from the audience. Does TIA contribute points into the diagnostic algorithm?
Emily, would you please repeat that? I was focusing, excuse me, on one of the chat comments.
Sorry. Does TIA contribute points into the diagnostic algorithm?
Would you please go back to that slide? That's about 4 or 5 slides.
Yep.
This is not published yet. It should be coming out very soon. And arterial clots, it's not defined here. And I don't know how it's defined in these new criteria, but just based on the last 20, 25 years, yes, the TIA will factor into that. And I wouldn't be surprised, and I don't know that, if TIAs get a few less points than a true, fully established arterial stroke.
Thank you. And thank you for that great introduction and great beginning to this conversation. So we are very pleased to start off our patient panel with Jimmy. Jimmy is from South Carolina, where he works in warehousing in distribution. Can you tell us and the other patients more about your clinical story and the symptoms that you have experienced?
Yeah, can you hear me okay?
Yes,
Yeah.
perfect.
Yeah, so I went to work one morning and I was having some mild to moderate chest pain. And I work in warehousing, so it's heavy lifting and stuff. So I thought maybe I just pulled something. And got home from work about 12 hours later and it had gotten worse, like the pain in my chest. When I breathed in, it hurt. And then my blood pressure was pretty elevated. I checked that at home. But so I decided to go to the doctor. And they, did your typical pneumonia test and x-rayed your lungs and, regular routine lab work. And the doctor wasn't finding anything. So we were waiting on one last test, a D-dimer test result to come back. And my D-dimer was pretty like really elevated. So that's when he decided to do a CAT scan with contrast on my lung. And they found a clot in my left lung. And it had caused like I don't know if it's veins or arteries in the lung, but the lower veins in my lung were completely, there was no blood getting to it. They were completely blocked by the clot. So, I mean, it shocked me. Like, I knew something was wrong because I was in pain and it almost felt like pressure on my chest, like somebody pushing on it. But when he came back and told me that's what they found, it shocked me because I'd never had an issue with it. It just completely out of the blue. So, you go and you never really expect something that serious. And so it just shocked me.
Understandable. And we really appreciate you sharing your story with us today. Can you talk about your condition today? And do you anticipate being stable going forward? What does your condition look like from today on?
Yeah, so I'm stable. I do well on the Xarelto that I take. Originally I was on Eliquis and then I had some bleeding issues. So I got taken off of that and then put on Xarelto. I haven't had any issues. It's been pretty good. I got diagnosed in 2021. I'm a double positive patient, so I have the anti-2 beta glycoprotein positive and the anticardiolipin. And then I was already on blood thinner by the time I saw the hematologist, so my lupus anticoagulant, we're not sure if it's actually truly positive or not, but we know that 2 of the 3 are. So yeah.
Okay, and how has your diagnosis changed your everyday life? What has changed for you?
Well, apart from the, obvious taking a pill every day, I'm very careful of, because I work in an environment that's high risk for injury, so I'm careful not to hit my head or get myself cut. tell people about it, like my friends and family, that I take this medicine. So if I'm ever in an accident in a vehicle or anything like that, they know to tell the EMTs or whoever I take this medicine. I also wear a bracelet. I don't have it on now, but to let doctors know or EMTs know that I'm on blood thinner in case something happens. So yeah, I think that's. I had another point, but I completely forgot.
No problem. How has your support system been?
Oh, they've been good. My family's supportive. I've had friends that will put little notes in their phone about what the name of my medicine is and how much I take, just in case I'm hanging out with them and something happens. So my support's been good. My hematologist is awesome. So yeah, it's been pretty good, given the circumstances. It's been good. So
Yeah, of course. Is there anything that you'd like to share with the audience about certain factors that really stood out to you and certain differences that you are seeing in your everyday life besides just taking the extra pill, or anything that you would recommend that they look out for?
Like I said, be
Anything come to
careful. Be careful when it comes to getting cut or hitting your head.
mind?
Hematologist tells me all the time if I get severely cut or if I hit my head really hard to go to the ER immediately. I would say it's hard because there's always that fear of what if it happens again.
Mm-hmm.
So I try to stay positive and hope that other people can stay positive. And it's difficult. It can be scary at times, but I'm doing well, and I know that other patients could do well as also. So.
Thank you so much for sharing your story, Jimmy.
Mm-hmm.
Really appreciate it. And then of course, if there's any questions from the audience, we'll get back to those towards the end of the roundtable today. But I would like to call on LaShanta here. LaShanta, can you provide some insight on different laboratory tests that have been mentioned and what they mean for the diagnosis of antiphospholipid syndrome from a laboratory perspective?
Yes. Good morning, or sorry, good morning. That's the wrong term. Definitely one. Good evening, everyone. We heard Dr. Mole talk about all of the laboratory tests to include some that are not usually associated with aPS. But although we have the list of laboratory tests available, and they seems really straightforward, right? We should be able to get a paper and check off what tests are necessary if we have a patient that's suspected to have aPS. But there are some laboratory workflow challenges that specifically come with laboratory testing that's associated with aPS. So we know that there are 3 main tests that the clinician should order when they're evaluating a patient for antiphospholipid syndrome. And the reason why we want to evaluate all 3 of them at the same time is it reduces the risk of a false negative finding. However, the laboratory is actually subdivided into many sections that have many different specialties. For example, lupus anticoagulant is actually performed in the hematology discipline, or better known as a hemostasis or coagulation laboratory, whereas anticardiolipin and anti-beta-2 glycoprotein 1 is usually housed in a different section. Sometimes it is housed in the molecular diagnostics section of a laboratory. Other times it is performed in the immunology section. Is the laboratory in the same building? Yes, but they are actually kind of subdivided. So what does that do for the diagnoses? Well, that causes the clinician in the laboratory to try to piece together information from different areas of the laboratory. Similar to what you see in many times in the team communication, there's some lapses that occur due to the team not being in the same area. So to try to mitigate some of that, some hospitals have elected to enter have offered their clinicians an antiphospholipid syndrome panel. Even with the panel, that really helps the clinician not have to remember what 3 tests to order, but it really doesn't solve the issue with the laboratory having the test being performed in at least 2 different sections. In addition, we know that the healthcare of the United States has started to change a little bit from having a really heavy inpatient focus to more of a hospital at home focus. So with that, laboratory tests are sometimes sent out to larger laboratories that are called reference laboratories. This also poses a challenge within the healthcare system because, again, the laboratory tests are likely to be sent to 2 different sections, and now, in addition, they're also going to be sent to potentially 2 different reference laboratories. So what can we do? What can patients do? What can the laboratory do? Well, they technically really have the same goal. They're going to be the advocates for making sure that they get all of the testing that they need and kind of helping the physician to keep track of their process through getting laboratory results done.
Thank you, LaShanta. That was a great overview for us. I'd like to introduce April now. April is from New Jersey and has had a long and difficult journey to her diagnosis, including multiple miscarriages. April, can you tell us more about your journey to your diagnosis?
Hi, thank you. Can you hear me okay?
Perfect.
Okay, I have some notes. I don't want to forget anything. First, I want to thank Stago for doing these roundtables and bringing awareness to antiphospholipid syndrome. I think it's more common than people think. And if we start the symptoms, maybe we can get people diagnosed a little earlier. So my journey to diagnosis is complicated, as I'm sure most other people's are, but looking back along the way, I believe it started with my first early miscarriage in 2014. We did some fertility treatments due to my age, and I did get pregnant again. Unfortunately, I also lost that baby as well, and that was at 22 weeks, which were both very devastating losses. That was in January 2015. And then right after that, I had some pain in my my calf, so I went to a doctor, I forgot, a vascular doctor, and they did a Doppler and discovered a superficial blood clot. So it wasn't a DVT, but it was superficial. And after those things, and I was trying to heal and grieve everything, I was sitting on the couch one night and my vision doubled. So it was a really strange feeling. It was scary. And I thought, wow, I hope that never happens again. And it did multiple times. And then I started getting other symptoms as well. So my fingers and my hands would go numb, tingly. My face would go numb on one side, my tongue sometimes. And these would happen really with no warning. I would be at work, I would be driving, and my vision would double, and it was really scary. So I started obviously going to doctors. My primary care picked up on, thank goodness, the combination between the superficial clot and the clot. What did she do? She sent me to a rheumatologist. Okay. I also had excruciating twisting pain in my back that would wake me up at night. So my PCP referred me to a rheumatologist after I went to her about the blood clots, miscarriage, and double vision. So the rheumatologist tested me, and I came back triple positive for lupus anticoagulant, anticardiolipin antibodies, and beta-2 glycoprotein. But I couldn't get a diagnosis yet because technically I didn't have an event, and that event would be the blood clot. So some doctors I visited: primary care, hematology, rheumatology, neurologist, ophthalmologist, neuro-ophthalmologist, OBGYN, and high-risk fetal medicine doctor, because I still wanted to have a baby. It was a long 6 months of trying to figure this out, experiencing multiple symptoms, also trying to obtain a safe plan for starting our family. But on June 25th, 2015, 1 month after my 39th birthday, I was at the gym when I had a stroke. Still can't believe it when I say it. I remember my rheumatologist coming into my hospital room and saying, now you have the diagnosis of aPS. So she started me on hydroxychloroquine, aspirin, and Lovenox, because Lovenox is safe when you're trying to have a baby. I still was not giving up. that dream. And that's how I got my diagnosis.
Thank you, April. Thank you for sharing that really difficult story with us. Can you talk a little bit about your journey to becoming pregnant and the treatments that you had to undergo in order to have your daughter today?
Well, a lot of the doctors didn't want me to try again. All of my blood work and my risk factors, but I still wanted to, so I had the best plan possible. So the high risk fetal medicine doctor and my rheumatologist and hematologist came up with a plan that I would stay on Lovenox. I did have to do IVF 3 times, which is very costly in addition to everything else. So I was on progesterone, Lovenox, aspirin, and hydroxychloroquine throughout the IVF and everything. And then when I got pregnant, I stayed on those things. The doctor, my hematologist, thought it would be best to have a planned C-section so that he can monitor my blood and the thinness and thickness of it. So I was actually admitted 2 or 3 days early from the planned C-section and was put on a heparin drip, which they, was going up and down and had to stop it and start it until I got it regulated. And I was able to have her on May 24th, 2017.
Well, I'm so glad that you were able to start your family and that you had the doctor support system in order to do that and the medical professionals to help you. Thank you so much for sharing your story, April.
Of course, thank you.
I'd now like to introduce Pamela. Pamela is from Tennessee, and she has visited multiple doctors over the years, going from specialist to specialist since the age of 18. She was being reported as anemic, high blood pressure, and then had a heart attack at the young age of 35. But she still had to experience more and more of these symptoms varying severity before finally being diagnosed with antiphospholipid syndrome. Pamela, can you please share more about your journey to your diagnosis?
Yeah, it's been crazy. It started kind of like April in 2014. Me and my now ex-husband found out we were pregnant. We were about 6 weeks, went into Vanderbilt, was there for a week, miscarried. At this time, they were still trying to figure out what was causing the anemia, where my blood was going, and everything else. And it took blackouts for different coming out, and like countless and countless of different doctors, different tests before I finally got an answer. And I think the only reason why we got an answer was because my spleen was enlarged 22 centimeters by the time they took it out, and I had a clot blocking my main. And 4 clots, 2 pulmonary embolisms, and right now my platelet count is up to 2,098, so I'm at a high chance for a clot now. I am triple positive also, and I got the lupus along with the factor V radiation. It's just been a mess. It's a lot of pain, a lot of blackouts, a lot of struggle, a lot of don't want to get up, don't want to do anything. Half the time I don't feel like I can. A lot of shots. It's just hospital visit after hospital visit. And then today had blood work. I have no blood. Found out I'm critically high right now for a clot, so join me. Waiting for that to happen. I have to start back on the shots, the Lovenox shots today too, which suck. But yeah, it's been a hectic journey. And come to find out, as of 3 weeks ago, my spleen's and my liver's enlarged, and they're talking about taking that out now. So it's a mess.
I'm very sorry to hear that. Could you tell us a little bit about your day-to-day and what that looks like for you?
Well, stolen weight. My weight just drops. I can't eat anything. They have no explanation why I'm losing weight rapidly like I am, or why I can't keep anything down. It's usually a lot of headaches, dizziness, tired, fatigue, don't want to do anything, too scared to drive because of the blackouts. Half the time, shortness of breath because of the embolisms and stuff. So it's a struggle.
Thank you for sharing your experience. What would you say is the most important thing that you've learned that could help others?
Don't play around. If you feel something's off, go get checked. Keep pushing. Don't let them tell you, oh, nothing's wrong. You know, I mean, it took them, I'll be 38 in October, 20 years almost to figure out what's wrong with me. So it's hectic. Don't give up.
Thank you, Pamela. Thank you for sharing your story and discussing your long journey to your diagnosis.
Thank you.
Our next patient is Chris. Chris is from South Carolina, where he was experiencing antiphospholipid syndrome, but went through a very lengthy journey for proper diagnosis and treatment. Chris, can you tell us about what led to your diagnosis and your experiences with your diagnosis?
Sure. Yeah. So I think it was 2000, end of 2016, 2017. I was at that point completely healthy. I was active, never had any health issues until this point. And I know we're passed out. Didn't know what caused it. My friend was there with me. They took me to the hospital, ran some blood work. Couldn't see anything right off, the bat. So they sent me home. They called it like syncope or something. So went through that. About 2 weeks later, it happened again. This time I went in, and this was the only time with all my clotting events that I had an elevated D-dimer. My blood sugar was really low too, and they thought that had something to do with it. So they ended up doing a CT, and they started looking around, and I had a DVT in my leg that I was completely unaware of, didn't show any symptoms for. My leg didn't hurt or anything like that. I had smaller clots in my hepatic vein and my splenic vein in my pancreas. So they admitted me to the hospital. They ran a bunch of tests. While they were there, they found the vegetation on the mitral valve of my heart, that's the first time I've seen that as with the new criteria. I never knew that had anything to do with aPS. So they found that, and then they put me on Xarelto. At that point, they didn't know what caused the clots. They couldn't give me an answer. They said, well, this is how we treat them. So you're just going to take the blood thinners for 90 days. And I took them for 90 days, and then I didn't have any more issues. Then 2018, I had another unprovoked DVT in my right leg, and it was completely occluded. My leg, exploded up, swollen, and a lot of pain. And then they decided that, okay, we're going to put you on Xarelto, and you're just going to be on it for life because you've had a second unprovoked clot, and we can't find a reason why. At that time, I didn't have an elevated D-dimer. But they actually did, and I didn't find this out till years after when I was trying to get disability. They did actually run some tests for aPS panels, and I did test positive then, triple positive, well, double positive. They didn't test for lupus anticoagulant at the time, but I tested positive for the anti-cardiolipin and the anti-2 beta-glycoprotein 1 antibody as well. But no one told me, so I didn't find out until years later when I was looking at medical records. And then it just started getting downhill from there. A few 3 or 4 months after that, I had a saddle PE. A lot like what Jimmy shared. I started having really, a lot of tightness in my chest, a lot of pain to breathe in. They were going to send me home, and there happened to be a resident in there that said, let me check one thing because my heart rate was really elevated. And they did the CT and found the PE. And I spent almost 3 weeks in the hospital with that. After that, I started getting more clots. I had superficial ones. I had DVTs in my arm. I've had over 10 DVTs in my lower extremities. I've had my subclavian vein included. Since then, and that was when they finally got me to a hematologist. At the time, I didn't have health insurance, so I was kind of in a lapse in coverage. I'd gone from one job to another. So luckily, there was like a charity program at the hospital, and they got me in through that. And they couldn't figure out what it was either. At one point, they said, "Oh, we think it might be leukemia. It might be this. It might be that." And it took me almost a little over 2 years to get diagnosed. I got diagnosed formally in 2019, June of 19. And then I tested triple positive. Then, well, technically double positive because I was anticoagulated. At that point, they put me on warfarin. And I'd been on Lovenox in between that as well. I failed on all on the Eliquis and the Xarelto. I've even failed on warfarin, and I've failed on Lovenox as well. Today my target INR range is 3.5 to 4. I had a TIA and a central retinal artery occlusion at a 3.4. So I was coagulated and therapeutic. I was, and to this day, my main symptoms is I get a lot of issues in my legs. I've had so many DVTs that my legs swell. I have really bad circulation. So that to some mornings I'd have to put the compression things on the machine just to be able to kind of get moving. And I just kept spending time in the hospital. At that point, my INR was so hard to regulate because they were still doing the finger prick. They weren't doing vein draws. So I didn't learn about that till I kind of got plugged in with some other aPS groups on Facebook. So it's been a lot of like advocating for myself since I got diagnosed. Luckily, I was blessed with a really good primary care doctor. I'm in a coverage like weird area when it comes to hematology. I don't have a hematologist. I'm in a study at Duke. So I mean, I've seen him twice, but my primary care physician, he manages my Coumadin. He handles I'm on the hydroxychloroquine as well. I take 81 milligram aspirin every day. I take a statin every day. For a while there, like I said, I couldn't even work. Luckily today, my symptoms have been better. I did have 2 TIAs right after the central retinal artery occlusion. Luckily, like I said, they were transient, so I don't have any. I get some numbness, but I don't have any really long-lasting effects. The symptoms when that happened was I didn't really realize what was going on. I just felt really tired, and my wife could see. She was well versed in the whole fast routine, so she could see that my face was droopy and that I wasn't really making much sense. So she got me to the hospital. That was during COVID, so that was a kind of a nightmare for her, and she was just terrified. And I really didn't know what was going on, but it can be scary. I know, like I said, advocating for myself when it comes to healthcare, I've had to learn that. There's a lot of discouragement when it comes to aPS, especially if you've had multiple, clots, because you're always like, you get that feeling again. You're like, oh God, what if it's another clot? And your doctor says, go to the ER. But then you go to the ER and they do it. It's like, oh, it wasn't a clot, or it is. And like, well, you're already on blood thinners. What can we do? So it can be discouraging at times. It can. Luckily, I've been fairly therapeutic for the last almost year. It's taken that long. It's taken since 2009, beginning of 2019 to get somewhat therapeutic for any length of time, like a month. So I've been able to keep it pretty therapeutic. I don't eat, like, my diet stays the same. I limit my vitamin K intake to a certain amount every month or every week, and I try to do what the doctors tell me. But it was really difficult to diagnose. If there's anything I can say, about my experience with aPS, it was how difficult it was to get diagnosed, and how little people seem to know about it. So, but yeah, I mean, that's been my experience with aPS so far.
Thank you for sharing that. Can you just highlight your day-to-day right now and your treatments that you are on?
Sure. So, I mean, day to day now, I still have the issues in my legs. I do have, I've got 3 stents. I've got a stent in my IVC. I had a filter, they took it out. So I've got an inferior vena cava stent. I've got one in my femoral vein in my left leg, and then I've got one in, I can't remember the name of the vein in my right leg to try to open things up. So I do still deal with a lot of like leg pain and stuff like that. I've managed to, I don't take any pain medicine for it. But today I'm a general contractor, so I'm back to work. Disability really helped in that kind of time where I couldn't work, but I was able to get back to work. I got a 1-year-old daughter. She turns 1 tomorrow, so she keeps me on my toes. So today I'm fairly active. My treatments haven't changed. I take the warfarin every day. I still take hydroxychloroquine, the aspirin, the simvastatin. I have regular. I get my blood checked every 2 weeks right now, or I'm supposed to. Sometimes it's every month. And I see my doctor every 60 days. But for the most part, I haven't had any real issues in the recent past. So day to day is pretty good, considering how it had been for a while.
Thank you. What is one thing that you wish you understood earlier in the process?
That's a hard question. I guess, I mean, a lot. I guess if we're being honest, a whole lot. I wish that I kind of understood. I didn't understand anything really about the disease. They told me, you have aPS, and of course, like most people, I just dug into Google and I was like, what is this? What is this? Like, I learned as much as I could about it, but I didn't understand the seriousness of it. Like when someone said, oh, yeah, you just got a blood clot in your leg, you're okay. I didn't understand how serious that was, and I definitely didn't understand how serious it was with the blood thinners. Like Jimmy had shared, I've had a lot of bleeding issues over the years, especially with my higher target range. So I wish I would have understood a little bit more about how important it is to really listen to your provider, and how serious blood clots can really be. Like I said, I'd never really heard much of them. Today it feels like I see something about a blood clot on every TV show that has anything to do with healthcare. Even seen aPS get mentioned a couple times on some sitcoms, so that's been pretty cool.
Thank you so much for sharing your story. I'd like to now introduce Mark. Mark is from Ohio and has had a spectrum of symptoms and related disorders. Mark, can you go ahead and tell us about your journey to your diagnosis and your experience?
Sure. So I would say my diagnosis was relatively quick, sort of similar to Jimmy. I was at work one day, had a little pain in my side, thought I did something at the gym, didn't think much of it. That was on a Wednesday. Kind of Thursday, same deal. Kind of Friday, the same deal. Friday night, middle of the night, pain was really bad. So couldn't get back to sleep. Took some aspirin, eventually got back to sleep, woke up in the morning, felt okay. Then the pain came back. Took some more aspirin. Went out, ran some errands, was gonna go to dinner. Probably 15 minutes from home, we're gonna stop at home, and the pain started coming back, and each time as it came back, it just ramped up significantly. It was like someone stabbing me every time I took a breath. And so ended up going to the ER because the pain was horrible. Had taken some more aspirin, it would kind of help. But they took me back. I do have a history of congestive heart failure that primarily manifests during exercise. That took 3.5 years to diagnose. And in that period, while waiting to be diagnosed, I probably put myself into acute pulmonary edema, I don't know, 75 times. You could hear the fluid in my lung from across the rooms, but they kept saying, oh, it's asthma. Nothing's wrong with you. So relatively, this one came pretty quickly. So my D dimer was elevated, did the CT scan, confirmed that I had a PE, was admitted, put me on heparin, got me stabilized, sent me home on Xarelto. The hospital list was like, oh yeah, just take Xarelto. You might have to be on it, might not. Didn't really seem all that concerned. Fortunately, I have a really good primary care physician. And so I saw him as a follow-up visit. And he said, well, we could just keep you on it forever. But, we can also send you to a hematologist and see why, because it was completely unprovoked. Go to the gym every day, don't smoke, hadn't been traveling. None of the triggers my blood pressure is low, none of the triggers, typical triggers. And so it took about 3 months to get into hematology. So saw hematology, they ran a battery of tests, and the first round of tests, all 3 of the antiphospholipid antibodies came back positive, including the lupus anticoagulants. And I thought I was on Xarelto, but I had to come off Xarelto because I was doing an endoscopy for some other things that were going on. And so I said, well, I'm going to be off it for X number of days anyhow. Why don't I just get the blood work done? So retested about a week later, was negative on the lupus anticoagulant, but I am double positive with sort of moderate titers for the anticardiolipin and the anti-beta glycoprotein, and then was retested in October. So it was July, October, and actually was retested again in April of the next year. So compared to some other things, it actually was a pretty fast diagnosis, and certainly faster than many of the people in this panel. And so I'm currently on 20 milligrams of Xarelto, and for the most part, that's, I haven't had every once in a while a weird bruise, but not a lot of unexpected bruising. It's weird when it happens more than anything. I think like Jimmy, I'm less concerned about like cutting myself when I'm cooking or something like that, because that I can see. It's more the big impacts, a car accident, a big fall. Those are the things that are much more concerning. And so I do wear a medical bracelet, and it does say that I'm on, that I'm on Xarelto. Partially, one disadvantage of Xarelto as opposed, for warfarin, there are more readily available options to stop the anticoagulation. That's one disadvantage of the DOACs, is that it depends where you are and whether the medical facilities are going to have those in stock.
Thank you for sharing your story with us. What would you say was the hardest part of the diagnosis, and what impacts you the most on an ongoing basis?
I think it's probably for me, it's more the combination of things, the complications that. So for Xarelto, if you're on Xarelto, you can't take Paxlovid.
How do I mute this?
So if you're on Xarelto, you can't take Paxlovid. I also have another
This is the thing.
autoimmune condition. I have another autoimmune condition, and for that I'm on immunosuppressants, which then means, if during COVID I had to do monoclonal antibodies, well, none of those work anymore. So I'm hoping we don't have a new, hyper strain of COVID, or I'll kind of be in trouble. So I do have to be, careful about that. I think I have to make more choices about where the kinds of things I do. I used to do a lot of biking. I was pretty much dead in the water because it seemed to trigger the pulmonary edema really badly. I kind of hoped I would get back to doing that. But once I had this diagnosis, I knew it was a really bad idea, because I've just had too many friends who've had bad road accidents. Not a good idea to get on a bike when you're on as much, on a lot of anticoagulation. When hiking a couple of years ago, pretty high on a trail that was not particularly accessible, I thought, if I had a bad fall here, that'd be really bad, because they would need a helicopter to get me out. So some of those things, I think, for me, that's probably where I see the biggest impact, because for the most part, I've stayed from perspective of this condition, I've stayed pretty stable, other than I think what a number of people have said is you're always worried, anytime I have a pain in my side, I'm like, oh, I've watched that. Is it another clot? And I did end up going to the ER about maybe a year ago, because I had an issue in my calf, and I'm like, it's kind of red, and it's been red for an hour, and it feels kind of weird. Better make sure it's not a clot. So it's that extra level of caution that I think we have to take. And I'm fortunate that I have really good health insurance, but I know that that's not something that everyone, many people in this country don't have that. And so that to me is a huge consideration for someone with this condition.
Thank you so much. We've now heard from all of our patients and their stories, and we really appreciate you all sharing your stories with us today. I'd like to ask LaShanta to share some of the key laboratory takeaways from today's discussion.
So for laboratory testing, it's really important that as laboratory professionals, and I do mean all laboratory professionals, ranging from your phlebotomist all the way to the medical directors of the laboratories where testing is being performed, it is vitally important that they know their roles in the diagnosis of aPS. Things that the phlebotomist has to know is the proper fill volume for your tube so that you don't have to come back in as a patient. Things that your medical laboratory staff that are performing your test have to know is how aPS is diagnosed and why they're doing the test. Lupus anticoagulant testing sounds very simple, right? It's the set of words on a piece of paper, but in reality, in the laboratory, it's actually two different pathways that we're covering for the patient. So the performing staff have to know those pieces of information. And nowadays, the laboratory professional has to be able to go outside the laboratory walls, right? So now we have to be able to gather information from scientific societies. So I encourage all of our laboratory professionals that are performing these tests, and even those that are interested in performing these tests, to make a conscious effort to be involved in the societies beyond what you would typically think of. Be involved in aPS awareness groups. Be involved in making a voice heard for your patient. If you see something that could be improved in your laboratory's process, be that advocate for the patient so that the patient can have a better story when they are looking at getting their blood work done. And the last thing I'll mention is that evidence-based laboratory medicine is everyone's responsibility. And that's what we should be providing for all patients.
Thank you, LaShanta. Dr. Mole, we have heard experiences from both males and females on this discussion. Can you speak on some of the key differences between antiphospholipid syndrome between men and women, and also discuss your key takeaways from today's discussion?
It's a big topic, antiphospholipid syndrome, and every patient is different. And the personal experiences we heard are pretty striking, I must say. Either a delayed diagnosis or a fast diagnosis, pregnancy complications that were recurrent. These people are very individual, and it comes down to that there is no one treatment that fits everybody. And when one thinks about best management of issues, one needs to take one symptom at a time. We heard about abdominal pain and weight loss, and one needs to question why is that and how can one address that? It's not sufficient just to have a diagnosis, antiphospholipid syndrome, and then group everything, oh, that explains everything. You still need to treat the patient. This also allows me to say that too often in practice, people, when they don't know what they're dealing with, healthcare professionals, they may grab to testing for antiphospholipid antibodies because they know this is a complicated topic. And then patients turn positive and you don't know, are the symptoms really associated with aPS or is it something completely different? So things get blamed on antiphospholipid syndrome that may just be coincidental. People have talked about autism or various things being due to antiphospholipid syndrome. But one really needs to take the individual patient, list the problems that they have and address each single one. If there is abdominal pain, It just means one needs to do an endoscopy, look at the stomach, look at the colon, look at the vessels, etc., and not just say it's aPS and take it from there. It's really difficult to make an overall comment. Everybody here on the call now has been diagnosed. Some of you have good physicians, others, and I see that in the chat, are looking for good physicians. Our healthcare system is difficult and broken. Mark is very fortunate. Others are less fortunate. For me, for healthcare professionals, really the information is what I had on the slides listed together. Be solid about that diagnosis, know what you're dealing with, know how to interpret the lupus anticoagulant, that you don't falsely label somebody with the aPS. Think about all 3 tests. Think about the level, that is important, and be aware of the various different symptoms. One of you said you didn't know that heart valve thickening was due to aPS. Physicians, healthcare professionals should know that they have a raised awareness. Could this be aPS? For the one of you who's going to see a physician and was asking what questions should I ask, a colleague of mine, Dr. Houghton from the Mayo Clinic, who trained here at UNC, and I have put together patient information publication, which is freely available on the web, and it's peer-reviewed. It gives an overall discussion of antiphospholipid syndrome, and maybe that is helpful for the person who's looking for a new physician who wants to know what questions to ask, or somebody else who's looking for information. There's a lot of information on the web, and some of it is accurate and others is inaccurate. So one needs to be careful not to get into the trap of getting wrong information and misinterpreting symptoms that are due to something else. Treatment is very different, and we've heard from many of you, some people get treated with blood thinners, anticoagulants, some with aspirin, lipid-lowering medications. Somebody mentioned Plaquenil. There are other medications that are being used, rituximab at times. It really depends on what other immune disorders people have. Mark says he has another immune system, so he probably is on other immunosuppressants for maybe lupus or rheumatoid arthritis or Crohn's disease or something else that could be associated with aPS. I don't have an overall message, Emily. These are moving and very personal stories that everybody shared. Very sophisticated presentation. I appreciate you talking about it.
Thank you, Dr. Mole. And with that, I'd like to open our Q&A discussion portion. We will answer as many questions as we can today. The first one, Jimmy, would you mind providing us a timeline of events for you?
Yeah, sure. I was, like I said, I forgot some talking points. I should have took
No
notes.
problem.
So I was diagnosed in 2021. So I went to the ER in October of 2021. And then following the PE test result, they referred me to hematology. I probably saw the hematologist maybe like a week or 2 later. I got in pretty quick. And then he started doing a bunch of tests, leukemia, all kinds of stuff, like you name it, he tested me for it. But he also tested me for the antiphospholipid antibodies. So as we've talked about before, you have to have continuous positive results. So it was probably, I got my initial positive result. He did it 3 months later, and I had positive results again. And then, he pretty much, I see him twice a year now, and he retests, and I've been consistently positive, high positives too, for 2 years. So my diagnosis, like Mark, was pretty quick. Within the span of 3 to 6 months, I had a positive, I had a diagnosis. It was pretty quick. So yeah. Does that answer the question?
It does. Thank you, Jimmy. Dr. Mole, can you comment on what causes the antiphospholipid syndrome to develop?
Yeah, April said that early in the chat. It's often it's an autoimmune disorder, so the immune system is confused and it makes these antibodies that are directed against some parts of our own body, which are phospholipids, and therefore they attack the joints and various issues, tissues. So it's an autoimmune disorder, sometimes without any associated disorder. Then we call it primary antiphospholipid syndrome. And it sounds like Jimmy has that without any additional autoimmune disorder. And sometimes it's secondary to some other autoimmune disorder, and that seems to be the case in Mark, even though I don't know any details, obviously. Occasionally, it can be associated with medications that used to be used in cardiology. It can be associated with cancer every so often, but almost always it's an autoimmune disorder that is either due to a known autoimmune disorder or out of the blue primary.
Thank you,
Mechanisms, how people clot, if that becomes asked, well, that's a huge topic, and researchers are working on that in many, many different fields, and there's a whole list of potential ways how people clot or have pregnancy losses. There's no one solution. It's not like this is the answer. There are multiple mechanisms and probably several coming together to make an individual clot, because not everybody with these antibodies has blood clots. And why is it that some people are triple positive and others double and single only? And why is it that some people have arterial events and others venous events and others have pregnancy complications only? It's a whole spectrum. It's not just one disorder per se.
Thank you, Dr. Mull. It looks like we have a few more questions for you as well. Could you comment? We had one question that says, could the mRNA vaccines cause our immune system to trigger the manufacture of the aPS antibodies? Do you have any comment on that?
Yes. So we know that the COVID vaccines that we use in the US can actually activate the immune system in patients who have had low platelets. And one of you described that you had low platelets and needed a spleen taken out, but I'm not sure about the details. But we know that people who have ITP, immune thrombocytopenic purpura, which can be associated with antiphospholipid syndrome, low platelets, that may get worse after the vaccine because the vaccine stimulates the creation of antibodies, and that may make some of the autoimmune disorders worse. So it is possible.
Thank you.
And then there's a question, Emily, if I may just jump to
Please.
that since I read it. Sheila asked whether the vaccine can cause blood clots. The vaccines we use in the US are not known to cause blood clots. There is the so-called adenoviral vector vaccine that is being used in Europe and some other countries outside the US. And very, very rarely that can cause blood clots, particularly around the brain, but also in other places, not common, called VIT, vaccine-induced thrombocytopenic thrombosis. But the vaccine itself, in general, in the general population, does not increase risk for blood clots. But you do wonder in patients with antiphospholipid syndrome who already are prone to develop antibodies, whether the vaccine that stimulates the immune system may lead to a higher level of antibodies and may be one of the reasons, probably not a strong one, to just tip a person over to blood clot, but that's not established. The rheumatologists use the COVID vaccines in patients they see with autoimmune disorders, lupus, rheumatoid arthritis, and there does not seem to be a higher rate of thrombosis in those patients. So I think it's not a significant overall huge concern, but in an individual, I would at least ask that question, could it increase thrombosis risk? But if you weigh against it, we do know well-established COVID infection causes blood clots. So I would say I clearly would recommend to my patients, do get the COVID vaccine. The majority are on blood thinners, like many of you anyway, so you're mostly protected from clots, even though we learned from Chris, I think they are not completely effective in everybody. But the risk of a blood clot with COVID vaccine is clear. The risk of a blood clot with vaccination in aPS patients is not defined and probably very low if it's there at all. So I would strongly advise for the COVID vaccines in everybody.
Thank you, Dr. Mole. Could you also comment on an increased platelet count and its connection to antiphospholipid syndrome?
So the question, do platelets increase
Yeah.
with? No, it's
Okay.
not as a medical, platelets can increase in anybody with an acute disease. Platelets have a tendency to go up whenever somebody is sick, be it with acute clots, with a heart attack, with an infection, with an autoimmune disorder. They are reactive. But the aPS by itself does not lead to an uncontrolled increase in platelets that would make people clot. That would be a different disorder. And I don't understand why I think maybe it was Jimmy or Chris, why you had a large spleen, but obviously there are many details in everybody that I cannot understand in a short period of time.
Yes, that was Pamela's comment.
Oh, Pamela. Mm-hmm.
Yes. Thank you.
Yeah, Dr. Mull, my hematologist drew my platelet count today, and I was up to 2,098. So he said I'm at high critical risk of a clot right now, but I'm not sick.
Oh, Pamela, but that's not surprising. You don't have a spleen, right?
Correct.
So most people after a splenectomy, after the spleen is taken out, have high platelets. Now, 2 million is, I think there must be 2 million. That's a very high platelet count. So you start to wonder about other disorders like essential thrombocytosis, ET, and such. But that would have to be considered and probably was already considered by your hematologist, and they may have tested you for something called JAK2 mutation and some other mutations that cause ET.
Okay, I'm not sure about that one because I know when they took my spleen out, 2 weeks later, I was in the hospital because I had clots all over my abdomen. I had one in my heart. I had a pulmonary embolism, and my valves are regurgitating blood. So
Pamela, that's complex, but it highlights one should not rush into blaming everything on antiphospholipid antibodies. Somebody with a big spleen and with high platelets, particularly high as 2 million, may have an underlying completely different disorder. And this one would be called ET, or essential thrombocytosis. So what you may want to do is ask a physician, is it possible that I have ET? And there are tests that we do for that.
okay, thank you.
You're welcome.
Thank you, Dr. Mole. We have one more question to finish our Q&A discussion. Could you comment on how you could use the ASH directory and whether or not this includes Canada as well?
So I put that into the chat if you go back in time, but you can also put into Google ASH find a hematologist. And I put the link into there. So then you can put in where you live, what city, how close in the surroundings you want to find a hematologist. And then you can put in the hematologist expertise. So you would put in thrombosis or whatever is listed there. I think it's thrombosis. And then names show up, and hopefully one of them will be suitable for you. And I would think it includes Canada, but I'm not sure. But I put in a name in Hamilton, Ontario for Francine, and she may have seen that. Dr. Mark Crowther is in Hamilton, Ontario. Hopefully that's not too far from you. And hopefully he's not the one that you need to get away from and to find a second opinion from somebody else. Mark is very knowledgeable.
Thank you, Dr. Mole. That is all the time we have for questions. Thank you to our audience for your participation and your great questions that you've asked tonight. Again, we appreciate our patient panelists, LaShanta and Dr. Mole, who were able to take the time out of their evening to join us and spread awareness of antiphospholipid syndrome. Your experiences were very valuable to learn about, and we are humbled by the serious daily impact you have experienced from antiphospholipid syndrome. I wish to thank the National Blood Clot Alliance, aPS Foundation of America, and the International Society on Thrombosis and Hemostasis, who worked with us to spread the word in honor of Antiphospholipid Syndrome Awareness Month. That brings us to the end of our roundtable discussion. Many thanks to our panelists and participants for joining us during aPS Awareness Month. I would like to close by just letting you know about our Ask Stago podcast, which feature patients with antiphospholipid syndrome. April actually was on there with us, as well as other bleeding and clotting disorders. You can access these podcasts on YouTube or Spotify, or through the QR code that you should be seeing on your screen right now. Thank you all for your participation and joining us tonight.